Hi, this is Dr. Alice Lee. Welcome to iCubed. This is EMN's latest blog, and I'm really excited that you've joined me. Each episode will be talking about a case that I've seen in my own practice, and hopefully we'll learn something by going through it like a clinician would. After all, most of us emergency physicians are clinicians. Each episode I have a guest. Most likely will be one of my partners that I work with. And so, Scott, why don't you introduce yourself?
Hi, I'm Scott Megna. I'm an EAD physician working in Arizona. I have trained in University of Maryland in Baltimore.
That's great.
And I've been practicing for about 17 years now.
Oh, wow. That's great. That's great. Okay, so let's just dive into this case. This is a guy I saw about, probably 8 months ago. And he's a 36-year-old guy who he looked fit, very fit. He came into the ED because of some chest pain and shortness of breath. He describes his pain as central. It's a burning pain and felt like his heart was pounding and was just working harder than normal. So then he describes waking up the day before in the morning with this chest pain, and he felt very short of breath. By nighttime, he felt really sweaty and was unable to sleep due to his symptoms. Today, he had some vomiting, not a lot. And then he also reported he had severe right inner thigh pain about 3 days ago, but there was no injury associated with that. Now, going through the rest of the history, talking with him, he does report that he has been taking kryptonite. I don't know if you heard of this.
Not familiar with that one.
Well, I wasn't familiar with it either, so I had to actually look it up, on shift. But it was a pre-workout supplement, giving these guys energy, I guess. He also reported that he administered his usual weekly testosterone. Now, he's a 36-year-old guy who's injecting himself with testosterone, and he did that yesterday, late afternoon, but that's his usual dose and usual time. There's been no changes of his kryptonite supplement, and he's had no changes in his testosterone injections. There's been no trowels, no history of clots, there's no surgery. So looking at the rest of his review of systems, he did already mention the pain in his leg a few days ago, but that's gone. There's no pain now. He did have some sweats, like he reported, His family history, there's some heart history. He doesn't drink, doesn't smoke, and doesn't use any drugs.
Except for maybe testosterone.
That's legal.
Sometimes.
Okay, very good. Excellent. So, Scott, what are you thinking by now? You're looking at this 36-year-old fit guy. He's short of breath. He looks a little bit tachypnic. He does look like he's a little pale and not feeling comfortable.
Well, certainly the big things we need to be sure that's not occurring is ischemic pain.
Right.
Things from like pulmonary embolisms or dissections.
Exactly.
But also, I think diaphoresis is always a big concern.
Yeah, exactly.
And the mantra that I learned was when your patient sweats, you should sweat.
Who did you hear that from? I've heard that from multiple.
I think that was Mattu.
Very good. All right, I think so too.
Remember that if your patient sweats, it ought to make you sweat.
So then we have a general picture in our head of his appearance. He's a little bit distressed and not really comfortable. We look at his vital signs and we see his temp is 36.7. His blood pressure is 162 over 114, so he's a bit hypertensive. Heart rate is 104, a little tachy. Respirations are 15, which is actually pretty normal for someone who is feeling dyspneic and having chest pain. Now, his sats are 90%, just a little bit low. I wouldn't expect that on someone who's 36 years old and fit. So I am legitimately a little bit concerned about this young man now. So looking at the rest of his exam, he is alert, he's cooperative and conversant. He's looking like he's in a little bit of distress. He's a little bit pale. His skin is clammy, like we referred to earlier, a little bit diaphoretic. There's no heart murmurs on his heart exam. He is a little tachycardic. We saw that on his vitals. There's no rubs or gallops. His lungs are actually very clear. And he's a very muscular guy. You know this guy is fit and he's a gym rat maybe. There's no edema of his extremities at all. You know, we get an EKG. What do you think?
Well, you know, certainly in here he's a little fast. He's 95, but no, there's no ischemic changes per se. Certain things we like to look at for pulmonary embolism, for instance, is maybe a new right axis, which I don't see here. Tachycardia, perhaps flip T waves in the anterior leads. He's got maybe a little depressed in the inferior there, but it's overall not a terrible looking EKG.
No, it's not. So they say the most common abnormal finding is sinus tachycardia. I mean, he's not technically in sinus tach, but he's a little fast. And the most notorious pattern for PEs, what is that?
Well, it's the
S1,
Q3, T3,
yeah.
which I've only seen once.
So this guy actually has that. S1, Q3, T3. He has an S wave in 1. He's got a Q wave, a little one in 3. And he's an inverted T wave in 3.
And he does.
Yeah, so, you know, it makes me even more suspicious at this point because I'm always looking for that pattern, even though I've really rarely seen it.
Right.
I think from my reading, it's only 10 to 20% of PEs that actually have that pattern. And then the chest x-ray comes back.
Very clear appearing.
Very clear, nothing overt. His heart size is normal. No, you know, it's not COPD, it's not cardiomegaly. His labs do come back, and we've got a normal white count of 10.6, hemoglobin is 16.6, hematocrit is 47.1, platelets are 145. His electrolytes are pretty normal. His troponin is 0.44. In our lab, that's a bit bumped.
That is up.
Yep. Makes you a little bit more suspicious. So then the CT, which you ordered right from the start, as we had thought about, PE is one of the differentials, and there you go. 36-year-old man with extensive pulmonary artery embolisms. There's a large amount of filling defect in the segmental and subsegmental branches of the pulmonary arteries in all of the lobes of the lungs. Boy, this guy's got lots of clot.
He's got a lot of clot.
A lot of clot, right? There's a small amount of thrombus within the distal right main pulmonary artery. So these are the films I got on the CT that day. I took quick snapshots of the actual images, and you can see where the shadows are. Even me, I'm not very good at reading CAT scans, but you can see those very clearly. There's just a lot of clot in this guy, you know, in the different arteries there. So like after the CT scan came back, I went back into the room. Thank God he was stable, and I asked him if I could ultrasound his heart. And here are the images that I obtained. And amazingly, it really is a classic right heart strain bedside ultrasound. You'll see the right heart strain, which is just the very first chamber you'll see on the upper portion of the ultrasound. And you can see it's a little bit hyperdynamic, but I was just like floored at how classic this bedside ultrasound of his heart, the reflected right heart strain. About probably 5 years ago, a wonderful educator, Dr. Teresa Wu, you know, held a course. So we all went down to University Medical Center, and we took her course, and probably a handful of us at this practice regularly practicing bedside ultrasound. And so I kind of became really enthusiastic after that course, and I'm kind of like a bedside ultrasound evangelist. So I'm always talking about it, and I'll be featuring a lot of my bedside ultrasound images on these episodes. All right, so. So this is a really great time to have a focused lesson on peristernal long axis. This case actually turns out to be a terrific illustration of the PSLA RV strain. I've put up the ultrasound of normal and the one on this patient, and it's amazing. I'm so excited that that this patient's ultrasound turned out to be classic. So I thought I would really emphasize this and throw in a teaching point or two. I have put the normal against my patient. This way you can see on the right, the PSLA normal view, you can see the RV is just below the surface. It's the first chamber you see when you place the probe on the chest, just distal towards the left ventricle. Then there's the aorta, there's the aortic valve, there's the left atrium distal to that, and the mitral valve. You can see the valves opening and closing kind of very nicely. There is the pericardium, which is a very, very hyperdense line just anterior to the descending aorta. The descending aorta is a faint, hypodense, round structure. If you look at the left side, this is my patient's PSLA view, and fortunately, it really amazingly turned out to be very classic for PSLA RV strain. The RV, which is just below the surface, you can see how much larger it is compared to the RV in the normal scan. And the RV is supposed to be about half the size of the LV. We can see clearly in the patient's PSLA that the LV, although hyperdynamic, is much smaller. The aortic valve, the mitral valve, the aortic outlet, all looks pretty much the same. You can't see the descending aorta on the patient's view, but you can see the pericardium very nicely as well. I was pretty amazed that this bedside POCUS was so classic. Of all the ultrasound skills that I've learned through the past few years, the bedside ultrasound of the heart is definitely the hardest one, and I still continue to learn along the way. But I think that with every scan we perform, we are learning. Just like any skill, the more you do it, the more proficient you are at it, and the better you are at obtaining the image. So even though this patient's ultrasound scan was done when he was quite stable and it was after the fact, meaning after the diagnosis was already made, I think it's still very helpful, because the more you see the abnormal in a stable situation and recognize the abnormal, you'll be able to recognize the abnormal in an unstable patient better. So I hope this little POCUS lesson is helpful for you, because it really helped me, actually. So the next day on this young guy, they did ultrasounds of his legs, and he had bilateral DVTs on a young 36-year-old guy. Now, I didn't really pursue the rest of his history. For instance, maybe he had a undetected like a hypercoagulable state or anything. But I guess the natural thing, the first thing I would think that would predispose this guy to his clots was his injection of testosterone. Mm-hmm. So I wondered about testosterone and VTE. I don't know why he was using that. I didn't ask. I assumed it was just because he was a bodybuilder type guy. I don't know if he competed. I don't know, but he was using kryptonite to, pre-workout, and then he's using his regular weekly testosterone. I can't imagine that he was hypogonadal, at that age. With each of these episodes, I would like to leave us all with two focuses, learning focuses. The first learning focus on this particular episode would be testosterone and venous thromboembolic disease. Mm-hmm. So recently meaning what, maybe 10 years or something, I'm hearing about, testosterone supplements in men, and then there's clinics that open up that promise men virility and increased energy and all that stuff, and there's just sort of mixed study results. Some are negative, some are positive, and so when I was kind of looking into this young man, why he would have so many clots at that age, and it seemed like his only risk was his testosterone injections, right? So I looked, and there's definitely mixed results to the different studies, but I did find a recent study in a British medical journal. It's interesting. It was actually a good article. So essentially, this was study done in England. They compared 19,000 patients that had VTE, either DVTs or pulmonary embolism. Okay, and compared them to 900,000 sort of age-matched normal, supposedly. And their conclusion at the end of this study was that there's definitely, to them, an increased risk of VTE in the men that were getting testosterone supplements. And that risk peaked at about 6 months, that risk, but then it declined after that. Of course, at the end of the article, they would talk about, there needs to be more studies, but it seems like if that's the case, it's a reasonable assumption that this young man, who you would think have no other reason to have PEs, has so many PEs. You would think that the reason he had them was because of his testosterone injection.
It makes sense.
Yeah. And so therefore, I thought this was sort of a different, interesting case to talk about.
Absolutely.
Learning focus number 2. What do you think? What should it be?
What should it be?
Yeah, what should it be?
Well, I think you really have to listen to your patient. You have to certainly pay attention to the patient's vital signs.
Yep.
And, listen to your clinical self, your clinical gestalt. You've been doing it for a while, and
it's kind of like the spidey sense.
The
right?
spidey sense, exactly.
That's perfect.
Like it.
That's great. That's a great learning focus to leave with everybody. I think in so many cases we shine as clinicians because we rely on our gestalt, our experience.
Absolutely.
And looking at a patient, even if the tests aren't quite right, or if they don't meet every textbook criteria of a particular diagnosis, right? ER doctors who've been in practice for a while, we have some little bit of a spidey sense. That's our superpower, right?
Exactly.
And so in all of these episodes, I really try to present a case that's very real. Obviously, they are real because they're my cases, but also they're slightly different than your classic textbook. But these cases highlight how critical our clinical gestalt is. So yeah, I think that's a great learning focus.
No, absolutely.
Have you had cases where you've thought, gosh, this is not quite, doesn't quite fit, but I'm going to pursue it?
Quite frequently.
Yeah, can you think of a case?
Banner Baywood.
Yeah, exactly.
Even today had a gentleman who had chest pain, mostly with really just with laying down.
Oh.
And while he's sleeping and getting up and moving around during the day.
Was he old, young?
He was older. And went to the cath lab, ended up going to the cath lab because he had continuous chest pain today, and he's being scheduled for cabbage.
So he was how old?
He was about 86. And the thing that got me is when it was occurring, he was sweating.
Perfect.
He was sweating.
Really?
Yeah,
he didn't have any chest pain?
He would have chest pain, but really only at night when he was lying down. And he'd get up, moving around during the day. Really had not much, really no symptoms. It was really all at night. And
so did he get a cath today?
And he got a cath today. He had triple vessel disease, 90 plus, and he's going for cabbage.
Wow. How about his EKG?
Now his EKG, there were little subtle elevations,
okay.
Especially in some of the anterior leads, and there was a little depression. It didn't quite meet STEMI criteria, but I called the cardiologist and had him take a look at the EKG. And he's, with the symptoms, he took him to the cath lab. And he's being scheduled for CABG.
That's fantastic. Did he have a history of coronary artery disease that you know of?
No history.
No way.
No history. Indeed, he had similar symptoms. He's from out of town. And he was worked up and had a normal stress test about 6 weeks ago.
6 weeks ago, he had a normal stress?
Normal stress test.
Wow. That's awesome.
Saving lives.
Yeah.
Stomping
so
out disease.
I think that clinical gestalt is very difficult to quantify, and it's just something you can't teach. There's a wise old Chinese saying that's basically translated means you can't teach experience.
Right.
You can only experience, and that's what clinical gestalt is. And you hear that every time you go to conferences. You hear lecturers talk about that being better in, let's say, pulmonary embolism rule outs, and what else? There's some other coronary artery disease, non-STEMIs, and so I think that's a terrific lesson to focus on.
I would say if a picture's worth 1,000 words, then an experience is worth 1,000 pictures.
Are you Chinese? You're sounding awfully philosophical right now. That's all right. Well, thank you, Dr. Megna.
My pleasure.
For joining me on this episode. And thank you all for listening, and we'll see you next time. Thank you. Bye.
Goodbye.